Welcome to the Quality of Life podcast, where we explore how hospice and palliative care may enhance quality of life for patients living with a serious illness. Here's your host, hospice and palliative care leader and educator, Dr. Millicent Burke-Sinclair.
Today, we're going to talk about palliative and hospice care, specifically being offered in rural regions. And so oftentimes we think about how beautiful it is out in areas such as far west, with rivers and mountains and views, and that's so incredibly true. But what we might not always think about is how challenging it could be to perhaps access the care that you need when you need it. Well, with Four Seasons, the care you trust, we bring care oftentimes right to wherever you call home. So I am joined today by two experts within our hospice and palliative realm that I'd love to introduce to you. We're going to let them introduce themselves as well. And then we're going to dialogue around how can we ensure that regardless of where you live in a rural area, you have access to palliative and hospice care when you need it most. So thanks so much for being with us today. We have Four Seasons physician, Dr. Michael Barnett, and we have Four Seasons nurse practitioner and director of our West Region and hospital programs, Dr. Jamie Rouse. Thank you both for being here. Four Seasons serves many counties throughout Western North Carolina, and we know how beautiful that Western North Carolina is. But what we also realize is that some of those areas are incredibly remote. We know that there are parts of our service area where there may not even be internet accessibility, where roads are not easily accessed, and where there's not necessarily the access to care that people need. So one of our goals here at Four Seasons is to make sure that we can reach rural communities, that we can provide trusted care wherever someone calls home, whether it's by us coming to where they call home, whether we make care accessible through a mobile clinic, or other options. Today, we're going to talk about how we make care possible. We have Dr. Michael Barnett, as we introduced earlier, a staff physician with expertise in providing care in rural areas, as well as pediatric palliative and hospice care. And we also have Dr. Jamie Rouse with us today, who is the director of the West Palliative Care program, as well as our hospital palliative care program, and she happens to be a nurse practitioner. We're really excited because both of these individuals have great expertise and insights into not only providing care to rural regions, but also to underserved populations. So Dr. Barnett, let's get started. You are in a remote area, super gorgeous area, and I believe that the Nantahala River is really near you, right?
That's right.
When you started out in rural areas, I believe it perhaps even was in Kentucky. Could you share a little bit about why you chose to study providing care in rural areas and how you feel living in this area now and how that's helped you provide care?
Mm-hmm. Yeah. So it all started in Ijevsk, Russia.
Wow.
So I actually, in college, I studied abroad and went to live in Central Russia. And it was a mission trip, and it was a trip to learn the language and to work with the local community there. And for others who have gone on mission trips, who've experienced that kind of work before, you know that it can be life-changing. It often changes the people who go more than the people there. Yes. And it was also where I first sort of realized and saw firsthand that great good can be done and great bad can be done with people who come in and don't understand the community and attempt to provide what they think is needed. Mm. And so when I came back from Russia, not only was sort of my world rocked, it was the first time I had really seen poverty for the first time and need. I decided to do medicine. I was actually in engineering school at the time and decided to do medicine. I went to University of Kentucky. And they started their very first rural track. Mm. And so I had an interest in sort of global health and in underserved communities and decided to sign up for this rural track. I did not grow up in a rural community. I was from the suburbs. And but a really neat idea, they paired students in small rural community, as I was in eastern Kentucky, based near Hazard, Kentucky, down in the mountains in eastern Kentucky. And they actually paired us with ag extension agents So out of the extension offices, so every county has one. And oftentimes these are folks who know their communities better than anyone. They know, obviously local agriculture, they know business, and they know the people of their community. And so a really neat idea to pair these med students with an ag agent who is kind of our handler for this whole period of my training. And what it was showing us is that to care well for a community, you need to understand the community and you need to be a part of it. So fast forward, I practiced for nearly 15 years in the city and did lots of other things before finally coming home to the mountains. And so now live just outside Bryson City. And I think, how is living here growing my understanding? I think that nothing takes the place of being in the community that you serve. And we certainly see that from our patients and families. One of the very first questions that you will get asked on every home visit is, where are you from? Where do you live? And not only are people testing and sort of seeing, are you one of us? Do you live with us? But there are also wonderful cultural differences of just each of our little communities. And if I cross through the gorge across the Nantahala, there's a different culture on the other side. And so just the joy of getting to know that and the differences and the beauty of that has been really wonderful.
Oh, thank you so much for sharing that. I love a statement that you made. And I hope that our listeners can just listen and remember that having care providers who live in your community and are a part of your community can really make a difference. And that's the benefit when you call Four Seasons. And in fact, when I think about a question that I have for Dr. Rouse, it makes me think about some challenges that providers may face when providing care in remote areas. And Four Seasons certainly has faced those challenges, but we also have tried and continue to strive to reduce barriers because we want to make sure access to care is always available. So could you just talk a little bit about how we provide care even in remote areas?
So I think one of the biggest challenges that we face, especially in rural Western North Carolina, in the region that Michael and I both serve in, is that we really have to struggle with terrain.
Yes.
And I mean, it's not even just where the patients themselves live, but Michael and I both know the terrain that we live in, right? I live in Soco Gap, which is the highest average elevation in the Appalachian mountain chain. And so I really do have to consider whether or not in the wintertime I can get out to go see the patient. And that's a consideration for several of our providers and team members, and then the safety of driving in the wintertime and, getting to some of these people's homes that have very difficult roads to travel. And the other thing is, you may have a patient that's a few miles from another patient, but it will take you a good long while to get there because as the crow flies, it might be a few miles, but as, these windy mountain roads require, significant drive times. And the other thing I think is, you did speak to limited cell service and limited internet access. And so for us as providers, it can make it very difficult to receive messages, to send prescriptions, to do the work that we would normally do in an office setting. And so I think all of us have gotten really good at knowing where to pull over, where you've got service, where you've got access. And so you can hook up to a mobile hotspot and get a prescription sent or get a message sent back to the team that's working at the office to keep you on track. And the other thing that I thought about is rural patients are just culturally different. We serve such a wide coverage area here in Western North Carolina, and the patients that we're serving in our North and South regions are often very culturally different from the patients in our West region. So I think the important thing about having people who live where they serve is that they better understand those patients that they are serving. And, they do ask you where you live, and so when I can tell them, oh, I'm just 10 minutes, 15 minutes down the road, it really does help build rapport, and it really does help that you can speak to the same grocery stores and the same environment, the pharmacies, and I think that can really help build rapport.
Well, and when you think about building rapport, building trust, we have added an addition with a mobile clinic. And one of the main goals with this is to help provide even more access to care. So could you talk about that a little while?
Yes. So we've deployed the mobile clinic. We have mostly used it so far in the further western counties, specifically in the Robbinsville area. That's a really spread out area. We serve a lot of patients in and around Robbinsville, and we have partnered with their health department to give us somewhere to park. They actually even have a RV hookup, which has been fantastic for us. So we can park there, plug in. Patients know where the health department is in Graham County, and they can come and see the provider, which also helps the provider that's in the mobile clinic see more patients and be of more benefit to more families. The other thing that we're working with is some of our oncology partners in the West. We've considered parking in their parking lots and doing mobile clinic, like as a walk-in palliative care clinic. So a lot of times patients are in the oncology office, they're having symptoms, they wouldn't mind being seen by palliative care if the palliative care person was there that day. And so we've been talking with some of our oncology partners about potentially getting that in place and making that happen so that we can serve more patients that really need us from a symptom management standpoint. And then another exciting thing that I've been personally working on with the Cherokee Indian Hospital is having a mobile clinic day there in their parking lot to be able to serve their patients directly.
Oh, that's fantastic. Thank you for sharing that. When I think about hospice and palliative care, whether it's a pediatric or an adult patient, it's really important that we are aware of and there to be a support, because the families of whether it's children or adults, there are challenges living in remote areas and accessing what's necessary for care. And so, Dr. Barnett, I wondered if you would be willing just to share a little bit about challenges that you've seen and perhaps what Four Seasons and how Four Seasons can help with that.
Yeah. Specific to our pediatric palliative care and our pediatric hospice, we are, we struggle to have pediatricians that are local, right? Have primary care. And so what it ends up happening is that our palliative care and hospice folks end up having to do a lot, helping with care coordination and making sure that kids are plugged in to providers, and finding them providers who are comfortable with complex, chronic, and serious illness. And that may not be in their small town. That may be, and they wouldn't know where to look, but because of our providers live in this area, they're like, oh, but I know someone who's just across the state line who is great taking care of kids like this. One of the other challenges that we have is, many of our local ERs don't do pediatrics or see very little pediatrics, especially complex pediatrics. The tendency is just to ship things out very quickly, get sent, my area to Chattanooga and to Atlanta. And so not only is there a big risk that kids are immediately going to get sent away from their home, from their community, but even simple things like getting a G-tube replaced or an NG tube, we often will find that the ER doesn't have the right tube, that they don't stock, it hasn't crossed their mind that they need to have this particular pediatric equipment available. And what we're able to do is actually coordinate with our local providers, our local ERs, our local EMS to say, hey, we've got this kid in your area. Can we make sure that we have this type of OG tube available in case they need it replaced? And folks are happy to work together. They just don't know. And then the other big challenge is around the pharmacy, is around medicines. And we've talked about that before, that pharmacy is challenging enough in our area. No 24-hour pharmacies. Many pharmacies closing at 6, and most not open every day of the week because of staffing limitations. So already we're struggling with, okay, can we get this medicine filled and picked up by Thursday because the pharmacy's not open again until Monday? Compound that now with the challenge of pediatrics, where many pharmacies either will not stock the medicines or are not familiar with the dosing enough to where they will not accept the pediatric prescription. And so some of these pharmacies simply will not fill the medicine, or it needs to be compounded. It needs to be specially made because of its concentration or because of the type of medicine. The child is so small. And so there are only a few compounding pharmacies in our entire Western region. And so it's really important that we make sure that those medicines are filled and ready when these kids are coming home, that we know where our pediatric pharmacy resources are.
That's true. Well, and we talk also about, for, say, the traditional thought of adult palliative or hospice patients, because again, in the remote area, access to resources can be challenging. And I know that Dr. Rouse mentioned that, but anything else you'd like to share with our listeners? Because I think what we want our listeners to hear is affirmation that we realize that while our areas of Western North Carolina, particularly the far west, are gorgeous and beautiful, there are some challenges. And we're right here with you to still make sure that you have access to care and resources that you need. So wondered if there was anything from the adult hospice and palliative perspective that you wanted to share.
Yeah, one of the things, I've been practicing serious illness care now for almost 15 years, doing inpatient palliative care work and doing really complex symptom management and very comfortable with all that. I've been amazed coming and living in the community that for a lot of our patients, getting to a primary care doctor is an ordeal.
Yes.
Yeah. Not only are they limited and overworked, but for a lot of our patients who have increasing symptom burden, who don't feel well already, who have limited resources themselves, getting across town or getting to the next town over to try to make it to a doctor's appointment becomes near impossible. And so that's actually really made me have to practice more medicine than I had when I was a subspecialist. And I could answer a very specific question and sort of sign off, and I did my part, and now you go back and they'll take care of the rest. And I have found that our team has really steps up to provide a lot of the rest. We really provide comprehensive care. And of course, when we don't know the answer or when we need help, right, we bring in the people that we need, but we're really providing a lot of direct care to families, in addition to just the subspecialty, this sort of complex symptom management and that of palliative care and hospice, really helping to provide management of some of their chronic diseases to make it easier for them to do well and to spend the time that they have with their families, with their loved ones in their home, not going back and forth to doctor's appointments.
Wow, and that has to be such a gift, because it can be so challenging just trying to navigate and figure out where to go, who to go to, and so forth. And so thank you for sharing that. It makes me actually think about a question for you, Dr. Rouse. When we think about the interesting geographic territory that's throughout Western North Carolina, it's also important that we pay attention to cultural differences. And you mentioned that earlier. So we realize that Eastern Cherokee Indian Nation land or the Qualla boundary is not necessarily all remote, but there are parts of the reservation that could be considered remote. You've worked really hard to forge relationships, to develop and understand the culture, and to even educate clinicians and providers. So could you share with us a little bit about how Four Seasons works to honor the culture as well as educate our team so we can provide really high quality care?
Absolutely. That particular population has my whole heart. So, and about, I would say 95% of the patients that I serve are members of the Eastern Band of Cherokee Indians. And when I moved to the area, we had bought a vacation cabin, and it was in Soco Gap, and that's a beautiful place to vacation, but it's a very different place to live sometimes in the wintertime. But what I realized is I live a mile off of the reservation, and I needed to know that population because there was a chance, when I graduated from grad school, that I would be working with them. So I did a windshield survey and some other things as part of my grad school work to learn a little bit more. And then when I transitioned to Four Seasons, I was hired to work directly with that population. And so it became very important to me to learn as much as I possibly could. myself and one of the hospice leaders have done Cherokee language programs and learned how to use various healthcare terms in their language. That's come in really handy with some of our dementia patients who the only thing that they can remember is Cherokee. And so, you can speak to them. I don't know a ton, but I can speak a few words, and it can really help make a connection. What we've done at Four Seasons, I think, has been very intentional about making sure that we are honoring this resilient people, that we recognize the history, and that we understand how the historical trauma that they've experienced impacts the care that we provide and how we are perceived. And, we want to make sure that, we're shedding the colonizer mentality, that we're going in there with a very intentional mind frame and being in their space and trying to make sure that they're comfortable. We've partnered with tribal physicians and the hospital. Our partnership with the hospital is incredibly strong, and we, recognize the resources that are available. We, collaborate with their particular pharmacy. We know the drugs that are on their formulary. We want to make sure that we are caring for this population as, as intentionally as possible to make sure that we're making their care easier. We're adding value to what they're receiving. And we're sharing that knowledge base with, everyone that comes to serve in this area. And another, one of the other things that we've done, Four Seasons as a larger organization, in the foundation with our palliative care immersion course, we actually have a historical trauma and impact on marginalized communities session that we teach to clinicians, across the country.
Thank you so much for sharing that. I think it's important and reassuring for our community to know that whenever they believe that they may need access to care, regardless of where they live, even if it is really remote, they can reach out to us, or regardless of their primary language, they can reach out to us, because we're here to learn and to be a support. And we're going to do the learning that's necessary to provide the best support and to provide the best care. And as we culminate our time, I wonder if each of you may be willing to reflect upon a patient, a family that you have been honored to provide care for, and just share a little bit about what stands out in your mind about this care, particularly perhaps a patient or family in a remote area.
Yeah, a patient that comes to mind is one that we've been able to care for both in palliative care and now in hospice. It was a great example of sort of adapting our care as needs were changing, as disease was progressing, and to not go into a lot of the medical details. Just a patient who lived alone, who has had a pretty difficult life and a lot of trauma, and that has really impacted relationships and really caused a lot of kind of alienation and estrangement. And so this was a patient who in many ways was alone, and not only had a great symptom burden, but had all the things that come with social isolation and loneliness. And our palliative care team had followed for quite some time, and really in many ways was helping to provide some socialization and providing some just kind of risk mitigation, like trying to manage medicines to not cause iatrogenic problems. So much of medicine is sort of starting things and forgetting that we started them, and one doctor not talking to the next provider, and next thing you know, you just end up having more and more side effects and problems. And so our team had done a really great job of managing this patient for a long time, and eventually came to the place where it was pretty clear that there was starting to be a significant decline. And I met this patient a couple times in his home, and it was pretty obvious that as his cognition was slipping, that he was no longer able to really manage his medicines or really physically to care for himself. And I watched our interprofessional team rally around this patient to try to figure out who were the people in his life, even if estranged, to help with decision making. The state got involved. And initially, the response was still sort of ignoring this man because of his history and because of he was known in the community and there was backstory, and a lot of people just didn't want to put up with him. And I watched our team say that's not acceptable.
Right.
Like, this man deserves to be well cared for. And I watched our social workers desperately figure this out. And to make somewhat long story shorter, we eventually were able to find a facility for him, to move him into a facility where he could get around the clock care. And he's there now, and we're taking care of him. And just to give an example of the social workers, the team continuing to care well for him, the team making sure that they've gone to his house to make sure that they brought some of his art and some of his to the facility so that he can have that around him in his room, have his home there. And I've been so proud to be a part of kind of a caring team that realized that to care well for someone, it's not just treating their pain, right? It's this whole social, emotional, spiritual,
whole person
care, whole person care.
And as you were just sharing that, I have another question for you, because it made me think about something that Four Seasons strives to do with great excellence, is make sure that we have a full care team in every area that we provide care. And so you yourself as a physician were involved, other providers, perhaps like Jamie as a nurse practitioner, you mentioned a social worker, but could you just take a moment and share with listeners about who else makes up a care team and how might that help provide care?
And this is a great example of that. Not only was social work involved in helping with all of this, just making sure he was well cared for, and in the dynamics between a estranged family. Our chaplain is involved, and this is a patient who has considerable religious trauma, sort of a history of mistreatment by religious communities. And so to have a chaplain who can come in, with a spirit of curiosity and to just be present with him. He's standoffish to sort of formal religious structures, and just to listen and let him process some of this. But he's still struggling with these big existential questions that we all are. Our music therapist has been involved, and that's been amazing because, this isn't just a performer, although she is an amazing performer. She's a therapist, right? Like, she is a skilled therapist who is helping patients process what they're going through in a way that sometimes has to be done beyond words, right? And for this man especially, sometimes struggles to process it verbally and to think that through, and to find outlets for him and he loves music. So to connect with the music that's familiar and known and comfortable to him, and to process some of the emotion and the grief through the lyrics and the music that he already knows, that's been amazing.
Oh, thank you so much for sharing that. And as we hear from Dr. Jamie Rouse, one thing that I love in knowing is, as you mentioned, physicians, nurse practitioners, chaplains, social workers, we have nurses, we have CNAs, we have volunteers, I might have missed a few. Four Seasons Care is all about listening to what's most important to that patient and their loved ones, and making that quality care beyond just what one may think, but it's that whole person care. It's even that whole family care, and whomever they identify as family. So, Dr. Rouse?
As Dr. Barnett was talking, I was kind of marinating on all of the patients that we have served and all of the examples. And I think the thing that really sticks out to me is how powerful it is to provide care in the home or where the patient calls home, and to be able to modify the way that you're doing things to be of the best benefit to the patient and the family, right? So the patient that came to mind for me, this is not a current patient. She has since passed away, but she was a very impactful patient for me, and typically share a bit of her story. Young patient, Native American, recurrent breast cancer. So she had a substance abuse history when we received her referral in palliative care. It was asked that I rescreen it as the director, because there was some question about whether or not we would accept her, because the substance abuse was not remote. It was a more recent history. And I decided that the right thing to do was to admit the patient and provide her with the care that she needed. So we started to serve her. She was very heavily impacted by historical and personal trauma. She was disconnected from her oncology service, and that's how she ended up with recurrent cancer. And then she also had a lot of, impactful history that made her connection with the healthcare community really difficult for her. And so we were able to kind of come in and really just spent a very, very much of our beginning relationship just establishing trust. The other major challenge to care for her was housing insecurity. So she was couch surfing at various family members' houses, and this was during COVID. And so we were able to utilize our telehealth services to provide her with care right where she was at, regardless of where she was. She could reach out to me the day of the visit and say, Jamie, I am not going to be at my son's house anymore. I'm at my daughter's house, and I don't know how to tell you to get here. I don't even know her address, and I would be able to say, okay, well, let's do a telehealth visit, right? And could still modify medications and keep her comfortable. And I think that level of flexibility really helped build trust, and it really was so impactful for this patient. It took me a very long time, but once we had her trust, we were able to help her through the entire process. She did eventually transition to hospice and was cared for by our amazing hospice team in conjunction with Cherokee Indian Hospital, where we can do GIP services. So she was able to have a death with dignity in a beautiful environment, surrounded by friends and family and loved ones. And it was being able to really meet her where she was at and give her what she needed at the time was so impactful for me, for the rest of the team. The palliative care team also has nurses and social workers that get involved with patients, and all of us just, we adored this woman, and it was just, it was really nice to be able to be of a benefit to her and her family and to help her reconnect with her children. And our social worker was instrumental in kind of helping her reforge some of her relationships and being present for really detailed conversations. And, she also had some existential concerns, and we were able to pull in the hospice chaplain even before she transitioned to hospice. He's so fantastic to help us out in palliative care as well, and kind of help talk her through some of that during a hospitalization. We were just, it was just really nice. It was just a really good experience, not just for her, which I hope it was, but for all of us, right? When you can do the right thing at the right time and be fully present for a patient and get them what they need, move mountains to make sure, literally move mountains to make sure that, she's getting seen and she's getting, the medicines and the prescriptions that she needs. It makes you feel like you're making a difference.
Thank you so much for sharing that. And for our listeners, I hope that you come away from this time and knowing that regardless of where you live, we are here for you. We care about you, and we're here. All you have to do is call, or you could go to our website at www.fourseasonscare.org. Thank you for listening.
The Quality of Life podcast is produced by Four Seasons, the care you trust, providing award-winning quality hospice and palliative care to Western North Carolina. For more information, visit fourseasonscare.org or call 866-466-9734.